Bueno, buenas tardes a todos. Creo que se oye bien. Y bueno, enhorabuena a todos los que estáis aquí y agradecer que después de toda la jornada de trabajo, pues a estas horas pues estemos todos tan motivados, pues evidentemente porque la jornada así lo requiere, ponente sin duda pues excepcional. Yo primero agradecer a la cátedra de Semergen y evidentemente en este inicio del Cardiovascular 2023, Servicio de Cardiología, Semergen, pues por estas iniciativas y bueno, por ese aforo tan importante que tenéis hoy aquí y que ya el otro día un poco en la presentación que hacíamos a todos los alumnos de medicina, pues una de las cosas que contábamos era donde pues se pueden ver todas estas jornadas de mayores para que tengáis los alumnos, los estudiantes, el conocimiento y podáis acudir, con lo cual ya nos encargaremos de que en la página web, al menos en la intranet del hospital, pues evidentemente aparezca. Bueno, yo agradeceros este esfuerzo. La tarde los protagonistas son ellos. Yo, muchas gracias, Ramón, como siempre, Sergio, por invitarme. Muchas gracias por estar aquí y nada más, que tengáis una buena tarde, que a pesar del calor de dentro, también lo hay un poquito fuera, pero seguro que la jornada y el ponente pues lo va a merecer. Por lo tanto, pues bueno, enhorabuena. Gracias, Ramón, por tus iniciativas. Evidentemente, esa coordinación que, como bien sabéis, tenemos que tener entre atención primaria y atención hospitalaria, los profesionales de atención primaria que están hoy aquí. Y nada más, pues una buena jornada y muchas gracias, John, por estar aquí. Ya ves que el día soleado que hemos tenido para ti, por lo tanto, pues bueno, muchas gracias a todos y que disfrutéis de la jornada. Y gracias, John.
Bueno, bien, gracias. Sí. Buenas tardes a todos por estar aquí. Good evening, good afternoon, John. Thanks for coming to our hospital and our School of Medicine and this activity. Like as I said, it's an opening course lecture. For us, it's an honor and a privilege having you here in Santiago, in our hospital, in our School of Medicine. Probably all of you know J V McMurray very well. At least the physicians, the cardiologists, the internal medicine know very well the J V McMurray curriculum. And then, but John is a professor of medicine, of cardiology in the University of Glasgow, and is working in the Cardiovascular Research Centre in Glasgow. But probably John is beyond his Glasgow work. John probably is the most relevant cardiologist, but probably physician in the heart failure field. He has been involved and continues to be involved in the most relevant international heart failure guidelines, and also he designed the many clinical trials, mainly in heart failure, with the results of these clinical trials contribute to save lives, improve the quality of life of many patients, and is much committed with the public health services, the public health and education services, not only in the UK and in Scotland, but around the globe. And his research and his initiatives, I think, the most important is the translational results of his research, and these translational research into the patient treatments, as I said, improve the quality and the quantity of life of many patients around the globe. So, John, thank you for coming. As I said, it's really a privilege of an honor of all of us for having you these days here in Santiago. Thank you.
So I just need to figure out how to show my slides. Might need some help. Thanks. Thank you. So thank you very much for the introduction. It's actually my privilege to be here in this beautiful city. I made the mistake of never having come here before, and I had the chance to look around earlier today, and it's an amazing place, and I'm so delighted to be here. I apologize that I can't speak Spanish, and I probably can't speak English very well either. I'm an Irishman living in Scotland, and that's a very bad combination for speaking English in a way that people can understand. So my apologies. And even worse than that, Jose Ramon has asked me to talk about something that he knows much more about than I do, which is this particular type of heart failure, which is heart failure with preserved ejection fraction. And in fact, I think we met probably about more than 25 years ago when we were both doing research trying to understand what this type of heart failure was. And as you'll see in a few minutes, it's really only in the past 3 years that we finally began to make some progress in the treatment of the mainly elderly, often female patients who have this particular type of heart failure. So these are my disclosures, and this is an outline of what I'm going to try and talk about over the next 40 minutes. So I'm going to say something very quickly about the terminology, because the words we use can be terribly confusing. I'm going to say something briefly about the diagnosis of this type of heart failure, because it's not easy to talk about, and it's actually, I think, quite difficult in some ways. I'm going to talk about treatment, and that's where, as I mentioned, at long last, after many years, we finally got some breakthroughs. And I'll finish by telling you about some things to look out for, some new clinical trials that are underway. So let's start with terminology. And over the years, there's been all sorts of words used to describe patients with heart failure, talking about systolic function and diastolic function, talking about ejection fraction. And currently, the way that we divide patients with heart failure into different groups, some people call these phenotypes. I don't think that's a good word. They're just categories described by ejection fraction. And the patients that we're talking about tonight are people with an ejection fraction of 50% or greater. Now, there's some very important words at the bottom of this slide, which are that all of these dividing lines are completely arbitrary. That's probably an English word that might not translate very well, but they have changed over the years and will probably change again. And when somebody gives this lecture in 5 years' time, I'm pretty certain that they won't have a figure that looks like this. But at the moment, what we mean by heart failure with preserved ejection fraction is having an ejection fraction of 50% or above. But just to say very quickly, for those of you who maybe don't do cardiology, an ejection fraction measurement isn't a completely precise and reproducible and reliable measurement. And when I say 50%, that can really mean anything between 43 and 57%, depending who's doing the investigation, what machine they're using, what condition that they did it in, what condition the patient was in when they did the measurement. So again, it's very artificial to think that there are clean dividing lines between these different categories. So let's talk about diagnosis first of all. And in fact, there are interestingly 2 recent documents that came out that say a lot about how to do this. One was in the main journal of the American College of Cardiology. It's not a guideline, it's a consensus document, but it's close to a guideline. It's an official American College of Cardiology document. That's the one in blue at the bottom. And then there was another one that myself and some colleagues wrote, which was in the heart failure subspecialty journal, and neither group knew that the other was writing this document, and they were published almost at the same time in the 2 different journals. I'm going to focus on our document for the diagnosis part, and this is the sort of diagnostic algorithm. And I'm not going to go through this in great detail, but really it's about probability. So the problem with heart failure and preserved ejection fraction is that it is to some extent a diagnosis of exclusion. You need to exclude other things before you can be confident that the patient has heart failure with preserved ejection fraction. And in this diagnostic algorithm, the first point is to make sure that you've excluded other specific cardiac causes for your patient, for example, being breathless or having peripheral edema. And there are a whole bunch of other things that can masquerade as heart failure with preserved ejection fraction. For example, pericardial disease can be difficult to diagnose. Don't forget things like aortic stenosis. And one of the things that everybody's talking about today is cardiac amyloidosis. So there are many different specific cardiac problems that have specific treatments in many cases that can cause what looks like heart failure with preserved ejection fraction. So you've got to rule out those. So try and make sure that your patient doesn't have another specific cardiac cause. And then if your patient has typical signs and symptoms of heart failure, have got an ejection fraction above 50%, then it's likely that they do have heart failure with preserved ejection fraction. But you can try and be more certain by using one of the 2 scores that are available. And these 2 scores, one is an American score, one is a European score, are shown in this slide. And the more points you have, then the more certain you can be that your patient has heart failure. I don't really know anybody who uses either of these to be truthful. And most people don't find this score, which is the European score, very easy to use. I think if any score is used, it's probably this American score over here. But what these scores really say is that if your patient has the typical background of somebody with heart failure and preserved ejection fraction, so that's often having a history of hypertension, maybe having atrial fibrillation, being overweight or obese, then if they've got the clinical symptoms and signs of heart failure, then it's probably heart failure with preserved ejection fraction. And if you're still not sure by the time you've got to this step of the algorithm, then there are other investigations that you can do. You can do an invasive investigation. This is probably the gold standard. So if your patient has an elevated left ventricular filling pressure at rest, then they have heart failure by definition. But again, at least where I work, not many patients go for cardiac catheterization just to document their left ventricular filling pressure to prove that they've got heart failure. You can also look at their filling pressure non-invasively, and in both of these two examples, the recommendation is to do it not just at rest, but in exercise, because some patients can have a normal left ventricular filling pressure at rest, but on exercise, the filling pressure increases excessively. But you can see now this is getting quite complex, quite involved, and increasingly less practical for most doctors in most practices in primary care or in hospital. And this is really for a very specialist investigation. But I honestly think that most doctors can make the diagnosis without having to go this far down the algorithm. So that's all I'm going to say about diagnosis, because I think it's hard to talk about. The problem is that you could give a lecture about diagnosis, you could give a lecture about treatment, and probably give 2 lectures about treatment, so I have to be quick. So now I'm going to turn to treatment, and when we talk about treatment of heart failure with preserved ejection fraction, we usually talk about 2 different things. We talk about treatment targeted at heart failure itself, and we also talk about treatments used for the many comorbidities that these patients usually have. And those are, again, almost 2 talks in themselves. But let's start by talking about the treatment of heart failure. Now, in 2012, when I chaired the ESC Guideline Committee, this is what we said about the treatment of heart failure with preserved ejection fraction. In 2016, Jose, you were on this guideline committee. It was exactly the same words. We had no treatment. And that was because all of the large trials that we'd done to that point had not shown any benefit of treatment. And it wasn't until 2019 that we got the first suggestion that a treatment might work. And then subsequently, in the next 2 or 3 years, we finally got a real breakthrough, which I'll come on to in a moment. But in 2019, the first sign that something might work in these patients came from this trial called Paragon Heart Failure. And Paragon Heart Failure was a trial testing the effect of something called neprilysin inhibition. So most of you who treat patients with heart failure will know about neprilysin inhibition in patients with reduced ejection fraction. From the Paradigm trial, we have a drug that is a combination of an angiotensin receptor blocker and a neprilysin inhibitor, sacubitril. We tested sacubitril in this trial as well. So the 2 randomized treatment arms in this trial were patients getting sacubitril valsartan and patients getting valsartan. So this was a test of sacubitril. You may be wondering why people were getting valsartan at all. The reason is that most patients with heart failure and preserved ejection fraction get a renin-angiotensin system blocker. It's not entirely clear why that has been the case. Maybe to treat their hypertension, maybe because they've got diabetes and chronic kidney disease. But the fact is that in the community, about 85% of people with heart failure and preserved ejection fraction get a renin-angiotensin system blocker. So we randomized everybody to a renin-angiotensin system blocker, but this arm, as you can see, also got sacubitril. And unfortunately, this trial was not positive. The upper 95% confidence interval, as you can see here, around the rate ratio was 1.01, and the p-value was just above that critical 0.05. So although it looked like sacubitril on top of valsartan reduced the risk here by about 13%, it was not statistically significant. So when we saw these results, we were very disappointed. But there were two subgroups that had a significant interaction. So when you design a clinical trial, you pre-specify certain subgroups that you're going to look at. And one of the subgroups that we pre-specified was to look at patients according to their left ventricular ejection fraction. And we said we'd look at patients below or at or below the median. So the median was 57%, or above the median. So basically split the population in half according to their median ejection fraction. And what you can see here is that, what you can see here is that patients with an ejection fraction at or below the median seem to get a substantial benefit at 22% relative risk reduction, but patients with an ejection fraction above 57%, no benefits. So is that true? Is it not? I'll come back to it. One of the problems when you do clinical trials is you always have to be suspicious of subgroups. Is this just a chance finding? Could it be real? There's a whole number of ways you can try and answer that question. One of the most important ones is to see if you can find any other external evidence that supports that finding. I'll come back to that in a moment. But before I do that, I just want to show you a better way to look at that sort of analysis. So, of course, as I mentioned, we have the Paradigm trial and the Paragon trial. So this is our heart failure with reduced ejection fraction trial. And if you put those two trials together, then you can look at ejection fraction as a continuous measure. And you can do an analysis like this, which is a much more powerful statistical analysis. And what you can see here, this blue line is a continuous hazard ratio. The dotted line, the shaded blue area, these are the 95% confidence intervals. This horizontal line is hazard ratio 1, in other words, unity. So if the hazard ratio is below 1, there is a significant benefit of sacubitril valsartan compared to a RAS blocker, so sacubitril versus no sacubitril. And you can see that the hazard ratio is below 1 up to an ejection fraction of between 55 and 60%, suggesting that there might be some benefit. So is this real? Is it a chance finding? Do we believe this? Because it's very important whether or not we actually want to use this treatment in patients with an ejection fraction at least up to 55, 60%. Well, I'll show you two additional bits of evidence that I think support the belief that that is a real finding. So one is from a new trial published just a couple of months ago. This is a much smaller trial. It was a trial done in patients mainly who'd been recently hospitalized. So HFpEF patients with a recent admission to hospital, or at least patients with an ejection fraction above 40%, recent worsening heart failure, randomized again to sacubitril valsartan or valsartan. This was a small short-term study, so only about 460 patients, only 8 weeks of treatment. The primary endpoint was a biomarker endpoint, reduction in NT-proBNP. We think that's a good surrogate for reducing wall pressure, reducing left ventricular stress, reducing filling pressure. And you can see that compared to valsartan, sacubitril valsartan did reduce NT-proBNP, reduced it actually very quickly. But what was important was in this trial, because of what we'd seen in the Paragon trial, there was a pre-specified subgroup analysis, which was to look at patients with an ejection fraction of 60% or less, and look at patients with an ejection fraction above 60%. And this is what was found when that subgroup analysis was done. So you can see here that these patients clearly got a significant and actually substantial reduction in NT-proBNP, which we think of as a favorable finding. These patients had no effect. So this is corroborating evidence, biomarker evidence. There was also a pre-specified analysis looking at the patients in this new trial, Paraglide, with the patients in Paragon heart failure who were similar. And in Paragon heart failure, we had about 620 patients who were like the patients in this trial. So we said, before we saw the results of Paraglide, we would put these two groups together. That gives us more power. We would look at that, and we would combine the two trials, all the patients in the two trials. So here's that subgroup of now about 1,000 patients. So 620 from Paragon, the 400 from 460 from Paraglide, and here you can see overall, and here you can see again the pre-specified subgroup analysis according to left ventricular ejection fraction, and you can see that again the patients with an ejection fraction below 60% or below had a significant benefit. But this time, this isn't NT-proBNP. This is clinical events. This is worsening heart failure, for example, leading to hospital admission or requiring intravenous therapy in the community, or cardiovascular death. And again, evidence that it does seem that there is benefit in those individuals. And if you do all the patients in the two trials, so now we've got over 5,000 patients, again, a very similar finding. So evidence that I think that this treatment does work, perhaps up to an ejection fraction of 60%. Can we find any other evidence to support this view that drugs that act through neurohumoral mechanisms might be beneficial in some of those patients with an ejection fraction above 50%? So the other group of drugs that we can look at here are angiotensin receptor blockers. So we did what was called the CHARM program, about 7,600 patients across the whole spectrum of ejection fraction. And we also have the iPreserve trial. And if you do the same sort of analysis, this is what you see. Now, remember, this is angiotensin receptor blocker versus placebo. So angiotensin receptor blocker versus placebo. And here's the continuous hazard ratio. And you can see very similar picture. So this is now external evidence from completely different trials, but the same picture that this neurohumoral blocking treatment seems to be beneficial in patients up to an ejection fraction of around 60%. And again, we can look at this in trials that we've done with renin-angiotensin system blockers. So we've got 3 completed trials, RALS, Emphasis, and TopCat. This is an ongoing trial I'll come back to. And same picture. So this is with a third type of drug. So now I'm showing you an neprilysin inhibitor, showing you an angiotensin receptor blocker, and this is a mineralic corticoid receptor antagonist. And I would have to say that collectively, these data do seem to suggest that drugs acting through neurohumoral mechanisms are certainly beneficial in patients who got an ejection fraction above 40%. That's our cutoff for heart failure with reduced ejection fraction, and maybe work up to an ejection fraction of 60%. And it was, in fact, these analyses which we presented at a special meeting that the US Food and Drug Administration held that persuaded them to approve in the United States sacubitril valsartan for patients with an ejection fraction above 40%. We don't have that approval in Europe, but it is that drug is approved in the United States, and I believe in about 40 other countries around the world for patients with an ejection fraction above 40%. And where you say it stops working, I think you can debate, but my suggestion is that it might be about 60%. So what do our guidelines in Europe say? What did our guidelines in Europe say about all of this? So these guidelines, believe it or not, are now out of date. They've been out of date for about 3 weeks because we published a focused update at the ESC Congress at the end of August, beginning of September. But until 3 weeks ago, this is what we had. And our guidelines, you can see here, recommended the use of diuretics and recommended the use of all of those neurohumoral agents plus a beta blocker, which I think is a mistake. I'll come back to that. In patients with heart failure, not with preserved ejection fraction, but in patients with mildly reduced ejection fraction, that is roughly between 40 and 50%. And the ESC guidelines still only recommended diuretics for the treatment of patients with heart failure and preserved ejection fraction. They did not accept the evidence that I've just shown you that these drugs may be beneficial for at least some patients with an ejection fraction above 60, up to 60%. So much more importantly, we've now got evidence that nobody disagrees about, and this is the most recent evidence, and this is for this amazing new class of drugs called SGLT2 inhibitors, first introduced as a treatment for type 2 diabetes, but very quickly proven to be beneficial in patients with heart failure and reduced ejection fraction, patients with chronic kidney disease, where they're the first ever drug therapy to reduce mortality, and as I'm going to show you in a couple of moments, effective in the management of patients with heart failure and preserved ejection fraction. So how do we know that? We know that because we have 2 large trials, around 6,000 patients each. Emperor Preserved, which was published first, Deliver, which was published second. These trials enroll patients with an ejection fraction above 40%, so they include mildly reduced and preserved ejection fraction. They were published in 2021. We published Deliver in 2022. And the 2 trials really gave almost identical results. So 2 completely different trials, different agents in the same class, but incredibly consistent benefits, because you can hardly see any difference between those 2 sets of Kaplan-Meier curves. You can see here the hazard ratio 0.80, 0.79, 20% relative risk reduction, 21% relative risk reduction, this composite endpoint of cardiovascular death or heart failure hospitalization, rapid onset benefits, small number you need to treat about 20 patients to prevent one of them having either cardiovascular death or heart failure hospitalization. And in addition, we have another trial that was carried out in patients across the whole range of ejection fraction. These were patients with heart failure, type 2 diabetes, who had all been recently admitted to hospital. They were started on treatment in hospital or within 3 days of leaving hospital. Again, very clear benefit. You wouldn't argue about that benefit not being obvious. You don't really need to do a statistical test to see that this is different. And again, the pre-specified subgroup analysis here, looking at ejection fraction divided at 50%, you can see here entirely consistent benefit in patients with an ejection fraction less than 50% and patients with an ejection fraction of 50% or above. Now remember, those two big trials I showed you before included people with an ejection fraction above 40%. So the big question was, when we did an analysis like this, were we going to see this same pattern that I showed you before? Would there be an upper ejection fraction limit for the benefits of SGLT2 inhibitors? So we have analyzed and published this, and we put together the DAPIHF and DELIVER trials. So now we're talking about 11,000 patients across the whole spectrum of ejection fraction. And this is what you see. So this is the continuous hazard ratio. It's consistently below 1 right across the whole spectrum of ejection fraction. The way to look at these figures from a statistical perspective is to look at the p-value for interaction. So what that statistical test looks at is whether ejection fraction modifies the effect, in this case of dapagliflozin, compared to placebo, and it doesn't. It's clearly non-significant. So ejection fraction does not modify the effect in this analysis of dapagliflozin. So suddenly we have a real difference between these treatments. This is a completely different picture, and looks like SGLT2 inhibitors are unique in providing benefit across the full spectrum of left ventricular ejection fraction, even in those patients with preserved ejection fraction that is above 60%. And the EMPEROR investigators, the other trials done with empagliflozin, have published the same findings. So for the first time ever in patients with heart failure and a really normal ejection fraction, we have strong evidence, reproducible evidence of a large benefit. And I think we don't like using the word breakthrough too often, but I think this really is a breakthrough because we have been trying for a very, very long time. We published the CHARM preserved trial 20 years ago this summer, and that was the first really large trial. So 20 years later, we finally got there. It took a while, but it was worth it. And I said those 2021 guidelines were out of date, and the reason they're out of date is that this was published, as I said, about 3 weeks ago. This is a focused update of the heart failure guideline. This is the first time the European Society of Cardiology has ever published a focused update of a guideline. There's normally a 4 to 5 year cycle. So the guidelines are updated every 4 to 5 years. For the first time ever, they've done an update after 2 years. And the reason this was done was because of those trials that I've just shown you with SGLT2 inhibitors. The 2021 guidelines were published just before the first of those trials. And because the evidence is now so strong, the European Society of Cardiology felt that it should update the guideline. It should do something unique. And it has given SGLT2 inhibitors for patients with an ejection fraction above 40% the strongest possible recommendation, a class 1 level A recommendation. You only get level A if you've 2 or more trials usually, or a meta-analysis, and class 1 is the strongest recommendation that we can get. So this is what the 2023 focused update looks like, although you will see here it's still only diuretics and SGLT2 inhibitors. None of those other drugs that I mentioned earlier that the evidence, I would say, suggests work, at least in some patients with HFpEF. And it is interesting to see that this, again, very recent American College consensus document, and I think in a way this is their guideline update as well, except they don't call it that, is quite different. So this was published just before the results of the DELIVER trial were available. So this is, you can see this is a yellow color with a green border. Green in the guidelines means class 1, yellow means class 2A. The words used to describe this are that currently the guidelines are class 2A, but they reckon that they would be updated to class 1 when the new American College guidelines are published, which is why they did this yellow with a green outline. So you'll see that both sets of guidelines are very clear about SGLT2 inhibitors. Both documents are very clear about SGLT2 inhibitors, but you'll see here at the bottom that the American guidelines are different, and they have a class 2B recommendation for these other drugs, a neprilysin inhibitor, mineralocorticoid receptor antagonist, angiotensin receptor blocker in patients with an ejection fraction up to 60%. And they also differentiate between men and women, which is very interesting. I've never seen this in any document before. The reason for that is that we also found in the Paragon trial that women seem to benefit more than men from sacubitril/valsartan, but women and ejection fraction is maybe the same thing, because women and men have different ejection fraction ranges, and women on average have a higher ejection fraction than men. So that benefit to a higher ejection fraction was also clearly then going to be a benefit, a greater benefit in women than in men, but we can talk about that afterwards. So very quickly, I can only touch upon this. The other aspect of treatment is treating comorbidities, and they're so common because patients with all types of patients with heart failure, but particularly patients with heart failure and preserved ejection fraction, have multiple comorbidities, and treating these can be important. This is the table from our document. Hypertension, just one thing to very quickly mention, sacubitril/valsartan is an extremely good antihypertensive in these patients, and we found that it was an effective therapy in people with resistant hypertension. Oh, sorry. So go back. People who remain hypertensive despite treatment with a diuretic, a calcium channel blocker, renin-angiotensin system blocker, and in many cases an alpha blocker and a beta blocker, you can reduce their blood pressure further by adding a neprilysin inhibitor. And that was even true in patients getting a mineralocorticoid receptor antagonist as well. So if you have a patient with resistant hypertension, sacubitril/valsartan is definitely a way of further reducing their blood pressure. Obesity, very, very common in patients with heart failure and preserved ejection fraction. There were 3 trials currently running looking at the effect of an obesity treatment in patients with HFpEF who also have obesity. One of these is published. So one of the 2 STEP HFpEF trials was presented and published at the European Society of Cardiology again about 3 weeks ago. These aren't big trials, so you can see here 529 patients. These patients were selected on the basis of having heart failure, preserved ejection fraction, and a body mass index of 30 or above. And the co-primary endpoints were improvement in self-reported well-being. That's the Kansas City Cardiomyopathy Questionnaire, KCCQ, or change in body weight. This, if you're interested in reading more about this, published in the New England Journal of Medicine. And here you can see the co-primary endpoints at the top. These were pre-specified secondary endpoints. This one was very interesting. So this GLP-1 receptor agonist used to reduce weight also reduced a marker of inflammation. And I haven't got it in this slide, but the biggest surprise of all was there was a reduction in NT-proBNP. We thought that actually NT-proBNP would probably go up because obese patients have lower NT-proBNP levels, probably because NT-proBNP or BNP is metabolized in adipose tissue, but there was a reduction in NT-proBNP. So the two co-primary endpoints were improved. These patients effectively lost a lot of weight, almost 11% weight reduction. They felt better, they walked further, and they had these biomarkers that suggested that this GLP-1 receptor agonist by itself or through weight reduction was doing other things that we think would be beneficial in patients with heart failure. So it's going to be very interesting to see the other two trials. There's a second trial like this in people who are diabetic. None of these patients had diabetes. And there's another trial with a different but similar type of agent. And almost certainly there will soon be a large phase 3 morbidity mortality trial set up in these patients. Chronic kidney disease, of course, is common. And again, I haven't got time to go into it in detail, but we know that SGLT2 inhibitors slow the rate of decline in eGFR over time. So you can see here that after an initial decrease in eGFR, your eGFR levels off. That rate of decline in eGFR is about the same for men and women in the same age group in the general population. And actually, so does neprilysin inhibition. I think maybe people have overlooked this about sacubitril valsartan, but sacubitril valsartan also slows the rate of decline in eGFR over time and even substantially reduces the risk of hard renal endpoints in patients with heart failure. So perhaps another reason why I would maybe favor being willing to use sacubitril valsartan, at least in some patients with heart failure and preserved ejection fraction. Atrial fibrillation, of course, is very common in these patients, and it's a whole lecture to discuss how to treat atrial fibrillation in these patients. One thing I would plead that you do is to use an anticoagulant, because one of the things that we see is that patients with HFpEF are less well treated with anticoagulants than patients with HFrEF. And the most alarming thing is that about 1 in 3 patients who have paroxysmal atrial fibrillation are not treated with an anticoagulant. Doctors use anticoagulants less commonly in patients with paroxysmal atrial fibrillation than persistent atrial fibrillation. But actually, in patients with HFpEF, the more dangerous type of atrial fibrillation is paroxysmal atrial fibrillation, which might surprise you, but that is something that we found consistently in our trial data sets. People are more likely to end up with the primary endpoint if they've got paroxysmal atrial fibrillation compared to persistent atrial fibrillation. And then last in this table is chronotropic incompetence. And again, I'm just going to raise this. I haven't got time to go through it in detail. I think you maybe know this trial better than I do. This is a Spanish trial, and this is looking at people with chronotropic incompetence who are on a beta blocker, and this is a very nicely designed, randomized, controlled crossover trial. So patients were studied on a beta blocker and off a beta blocker in random order, and when these patients were off a beta blocker, they exercised more, their peak oxygen consumption was better, they reported feeling better, and I think a lot of people are very interested in the idea that maybe we have been using beta blockers too easily in these patients, and that is one of the reasons why I think the ESC guideline might be wrong about recommending beta blockers in patients with heart failure and mildly reduced ejection fraction. And again, related to this whole issue of chronotropic incompetence, there are some interesting small pacemaker trials conducted in patients with heart failure and preserved ejection fraction. One of them suggested benefits, one of them didn't. I haven't got time to go into them in detail, and I'm not an electrophysiologist, but again, in the idea that perhaps some of these patients have a problem with accelerating their heart rate appropriately when they exercise, I think is an area of great interest for the future. And then lastly, something that we forgot in our document, but this is in the consensus document, is sleep apnea, very common in these patients. And then Jose, Ramon, you were contributed to this. So this is a nice document. I've skimmed through all of that very quickly. This document covers a lot of it in more detail. So I'm nearly finished. I only have a few slides left, and it's to look forward to the future. So what are we going to hear about in the next 2 or 3 years? So one of the treatments we think probably works in these patients, but we've not been able to prove it, is a mineralocorticoid receptor antagonist. There was a trial done called TopCat that had problems about patients being recruited who didn't have heart failure, patients being recruited who didn't take their drugs, and this was proven by measuring metabolites of the drug level in the patient's blood. So there are currently 2 studies underway with spironolactone. They've got very similar names. One's funded by the US government, one's funded by the German government. And these trials have struggled a bit during the COVID pandemic. But there is, I think, maybe a trial that's more likely to give us a clear answer using a different type of mineralocorticoid receptor antagonist. This is using a so-called non-steroidal mineralocorticoid receptor antagonist. The prototype drug in this class is a drug called finerenone. These drugs are supposed to have more selective activity in the heart to be less likely to affect the kidneys. This particular agent, finerenone, has been shown to be beneficial in patients with diabetes and chronic kidney disease, and we're currently studying this in a large trial in patients with heart failure and preserved ejection fraction, or heart failure and mildly reduced preserved ejection fraction. So we've completed randomization in this trial, over 6,000 patients, and we should have the results towards the end of next year. So I'm hoping this will be another breakthrough. The fact that it works in people with diabetes and chronic kidney disease suggests to me there's a good chance it's going to be beneficial in these patients with heart failure and preserved ejection fraction. And then one final trial I want to mention, only because it's interesting in targeting a completely different mechanism. So we've talked about neurohumoral systems for years. Recently, we've got the SGLT2 inhibitors, and we think about glucose, weight, metabolism, but inflammation may play a key role in patients with heart failure, particularly heart failure and preserved ejection fraction. And I showed you that reduction in high sensitivity CRP with semaglutide. Now there is a trial called Hermes that is specifically targeting inflammation. It's using a drug that blocks the IL-6 pathway. And again, it's a big trial that's going to enroll close to 6,000 patients. And the patients are being selected not just by having heart failure with preserved ejection fraction, but also by having an elevated CRP as a marker that they have more chronic inflammation. So again, if this trial proves to be positive, it's going to be paradigm changing because it's going to change our thinking about the pathophysiological mechanisms in patients with heart failure. I'm just putting these pictures up. I'm not a device person at all, but there's also an interest in devices. There's some evidence that implantable pulmonary artery pressure monitors can be useful in guiding treatment and in that way improving outcomes in patients with heart failure, both with reduced and preserved ejection fraction. And specifically in patients with heart failure and preserved ejection fraction, there is an interest in several different interatrial shunts. These devices allowing decompression of the left atrium. So if left atrial pressure is increased, and that's what's causing pulmonary congestion and breathlessness in these patients, then the thinking here is that if you can decompress the left atrium into the low pressure right atrium, you might relieve symptoms. Let's see, there are lots of trials going on. So to finish, my final slide, this is from the document that we wrote, and it's really a summary of what I've said to you. It does mention one other thing that I've been very bad in not talking about, and of course, that is exercise and diet, very important. There is trial evidence that physical activity, enhancing physical activity, can be good for these patients as well. So with that, I'd like to thank you very much indeed for coming along tonight and listening.
So thank you, John, for this fascinating summarize the state of the art of heart failure.
Did I say anything wrong?
No. With preserved ejection fraction and the expectations of the new expectations in this pathology, and probably changing the paradigm, as you mentioned in one of your last slides regarding the role of inflammation in this disease. Not much time. We have an audience also on the line, and I would like to thank the audience on site and also the web audience. But several friends of mine sent me the same question, and the same question is, what is about when you think the neurohumoral blockade, circulatory valsartan, this effect was related to the left ventricular ejection fraction, the rationale justifying this finding, and this was not found in the SGLT2 inhibitors. What do you think the rationale for the interaction with the ejection fraction for the neurohumoral blockade, and no for a new class of drug, in this case for the SGLT2 inhibitors?
So I think for sacubitril valsartan, it's probably pretty easy, because if you look at patients with heart failure, the lower the ejection fraction, the greater the level of neurohumoral activity. And even in patients with an ejection fraction above 40%, there is neurohumoral activation, but it's less. And as your ejection fraction becomes more normal, the neurohumoral activation becomes even less. So if these drugs are acting through neurohumoral systems, then maybe it's not surprising that it will be in patients who've got neurohumoral activation that will be benefit. The other thing is that those neurohumoral activity is increased in patients who've got systolic dysfunction. And you have systolic dysfunction even when your ejection fraction is 50%, maybe even 55%. If you're a woman, you probably have systolic dysfunction, even if your ejection fraction is as high as 60%. So I think there it probably all fits together. The SGLT2 inhibitors, I think, are the more interesting story because we just don't know how they work. They clearly don't work through neurohumoral systems. We know that if you measure their effect on renin, on sympathetic nervous system, there's no consistent effect. They don't work through neurohumoral mechanisms. So they're not going to be dependent in the same way on neurohumoral mechanisms as sacubitril valsartan, for example. So we don't know how they work, but it's not through neurohumoral mechanisms. So it's not surprising, perhaps, that they're not influenced by ejection fraction, by neurohumoral activity.
Yeah. So time for a final question. Yeah, there's a question.
So, do you think our role should be advice for us on the test that we should perform about the importance of addressing the comorbidities of the patient, the macrotypes,
Okay, so I can only talk to you from the perspective of the UK National Health Service. So, you might want to talk about the local. So we follow or at least when we talk to our GPs, we recommend following the European Society of Cardiology guidelines. So at the moment, that would mean using diuretics for decongestion, for fluid control, using an SGLT2 inhibitor, and then the key comorbidities to treat are particularly hypertension, and we actually usually recommend, if possible, if kidney function permits, using mineralocorticoid receptor antagonists, and then obviously atrial fibrillation, controlling the ventricular rate. Some patients we might think about ablation and anticoagulation. In terms of weight reduction, we have not been able to use semaglutide routinely. I don't know if you can do that in Spain, but the National Health Service in Scotland does not at the moment allow us to prescribe GLP-1 receptor agonist as a weight-reducing agent. So we don't have that option. But we do have other approaches to weight management. I think those are probably the most important things. I mean, obviously, I think the first part of my talk, which was about diagnosis, to make sure that the patient doesn't have something else wrong is important. So we would always recommend cardiac imaging. So make sure they don't have, I mean, a lot of the things on that slide were rare. The thing that probably is most important to make sure your patient doesn't have is aortic stenosis. And usually you'll know because there'll be a murmur. Sometimes there won't be. So I would say get an echocardiogram. If you can rule out any other specific cardiac pathology, diuretic, SGLT2 inhibitors, your two basic treatments, and then the other things I mentioned.
Yes. I have really a question about the primary care management. In the guidance, you recommend to begin dapagliflozin or empagliflozin when the patients arrive to the hospital in acute heart failure. What do you think, for example, the patient we are management in the same situation, but they don't need hospitalization to begin the same treatment?
So I strongly recommend using SGLT2 inhibitors. So I'm going to talk about those tomorrow morning, but they are the easiest to use and the safest treatment we have for heart failure. And in the UK at the moment, because our service is still struggling after the pandemic, we don't have the good service that you have here in Galicia. A patient can wait many weeks before getting an echocardiogram, and we recommend to the GPs that if you make a clinical diagnosis of heart failure, starting SGLT2 inhibitor, even before there's been an echocardiogram. And the reason we do that is that, as I'll talk about tomorrow morning, you can prove statistically that SGLT2 inhibitors have a clinical benefit within 2 weeks of starting treatment, really quickly. So if your patient is waiting to get an echocardiogram but not on an SGLT2 inhibitor, they're missing the benefit of that treatment. So it's as safe as a loop diuretic. So why not use it? So we would strongly recommend using it.
Yeah, to finish early, we will be here more than 1 hour discussing with John. As he said, tomorrow morning we have a new opportunity in this meeting room for discussing other aspects of heart failure. For sure, heart failure is the major challenge in heart failure is the heart failure management programs, because it's the more difficult cardiovascular disease to manage due to the patient's stability, and the role of the GPs plays a critical role, because in this hospital every year we admit more than 2,000 patients with the primary diagnosis of worsening heart failure. So this is a challenge. There's a challenge by these nurses, challenge GPs. It's a GP-centered disease. Otherwise, the cardiologist only looking for patients more concrete, more specific, more complex. But all the patient needs a close follow-up. This is, for me, the big challenge in heart failure is how to organize, to manage the heart failure in the area, and how to involve direct involvement of GPs and nurses, ambulatory nurses, in the management of the disease. Otherwise, you only put some solutions when the patients are unstable and again are admitted to the hospital. It's probably the more complex cardiovascular disease, not only due to the prevalence of the disease, but also to the complexity and the instability of the patients. Not the same that patients have an acute coronary syndrome. The vast majority of the patients are stable patients and other chronic conditions, but heart failure, this is for me, the big challenge is how to organize at local level the heart failure management. So thank you so much. It was really, as I said at the beginning, a privilege for us sharing with you your thoughts about heart failure with preserved ejection fraction. That probably is an example for personalized medicine, personalize the diagnosis, stratify the risk, and then personalize also the follow-up of the patients. And tomorrow morning, we will have a new opportunity at 8:15 here, also with a web transmission of the lecture, and John will be here tomorrow. Thanks for the online audience. Thanks for all of you from different parts of Galicia, and then the students, particularly the students of our School of Medicine. This was really an amazing experience. This lecture with J V McMurray here today. So thank you, and we finished this meeting with Alfonso. Alfonso Varela is our medical director. He is also a cardiologist, and he closed the meeting.
Only thanks, Professor McMurray, for your great presentation. It was an honor for all of us that you stay here with us in Santiago. Y nada más, muchas gracias a todos y damos por concluida la sesión. Vale.